Thank you very much. My thanks to Peter and Giorgio for my invitation to this beautiful city. It's 20 years since I last came, and I'm looking forward to seeing it again. Yes, we do respect Italians in Italy, and with 10 games to go, the Piazza Ranieri is all ready to go in Leicester. Okay, enough of this nonsense. We all know that surgery is the best treatment for early stage lung cancer. I just need to justify that now. Go straight to the conclusions. These are the reasons why I do advocate surgery to patients rather than SABR. It's actually of no greater risk than radiotherapy in the right hands. It has additional benefits in the high-risk patients, not only in removing their cancer, but it has physiological benefits to them as well. It always gives you a tissue diagnosis. The tumour stage will always be correctly assessed. Actually, local control with radiotherapy, whether you call it SBRT or SABR, is in fact no better than a wedge resection, of course. We have to agree that. And therefore, the long-term survival from radiotherapy is going to be lower than from a lobar or anatomical surgical resection. And therefore, surgery in the end is more cost-effective because of the greater long-term survival. There, that's the talk. Let's go through the evidence. You get radiation pneumonitis with SABR. There's no doubt about it. The rate may vary with the technique used, but you're going to get some collateral damage. There's no doubt about that. You may damage the rib cage as a consequence, and you do get a drop in respiratory function. There's absolutely no doubt this is not completely harmless to the surrounding lung, and you drop your FEV1 by about 8%, and that was a similar across the groups for those patients who had severe COPD and those who had moderate and normal lung function. So it's not without complications. This is not some magic way you can enter the patient's body, kill the tumour, and not do any collateral damage to the patient. And in the good hands, surgery is actually of no greater risk than radiotherapy. Properly selected and managed patients with modern surgical techniques, the mortality from surgery and the grade 3 adverse events are no higher. And these were the review here, I think you've seen from Crabtree, of 3 randomized controlled trials there. Now, importantly, when you're operating on patients with COPD, you may have additional benefit from removing the damaged emphysematous lung. And I'm interested that a lot of the doctors in the room are pulmonologists, and so you're aware of the volume reduction effect, that removing damaged lung tissue, COPD emphysematous tissue, may be therapeutic. So rather than the less lung you do, the better, the more lung you remove in these patients could be beneficial. We found many years ago that applying the volume reduction principle to lung cancer patients, their actual FEV1 went up compared to their predicted FEV1 from this volume reduction effect. And this is the sort of patient we're talking about. Middle-aged, COPD, small stage 1 solitary pulmonary nodule, poor FEV1, but hyperinflated. So residual volume over 200% predicted, not in respiratory failure, with a reasonably preserved diffusion capacity, although we will operate on these patients for volume reduction if their diffusion capacity is around or just below 40% of predicted. So in our hands, this patient will get surgery and not SBRT. And the reason for that is that his target tumour is in a target area for volume reduction. So by taking out his cancer, we'll also take away his emphysematous lung, we'll take away his hyperinflation, we should improve his lung function rather than deteriorate it. Now, SBRT can't destroy the whole lobe, otherwise you're not targeting all the radiotherapy onto the tumour itself. It's slightly more complicated if the target tumour is not in the target lobe. In this patient with upper lobe emphysema and a lower lobe tumour, in these patients we would do a VATS anatomical resection, a segmentectomy, and consider volume reduction of the other lobe And we have done that by endobronchial valve treatment, not just surgery, but it's obviously possible if you're in there with the thoracoscope to do volume reduction as well. So you can take away emphysematous lung tissue and improve lung function, which may counteract the deleterious effect of removing the tumour. And VATS is the key. Not damaging the chest wall, we found, was the most important thing, more important than preserving the lung tissue in these high-risk patients. We're operating on patients with FEV1s, as you can see there, down to 14% are predicted, and their predicted average was 33% are predicted, and we operate on those patients. And it is important to get a tissue diagnosis. And unfortunately, in some of the SABR series, you can see there that only 2/3 had biopsy-proven cancer, and PET was only used in 84% of patients. Now, I hope that those figures are improving, but you must have some fantastic radiologists if you can get 100% tissue diagnosis in peripheral small tumours. There must be some of the best interventional radiologists in the world to do that. You will undoubtedly fail to get a tissue diagnosis in 20% of those patients. We know that the tumour can be heterogeneous. We know the importance now of intratumour heterogeneity and the implication it can have for future therapy. Much better to take the whole tumour out rather than just a few cells, allowing more accurate tumour characterization and therefore the selection of tailored adjuvant therapy if there's found to be nodal metastases. And I'm afraid that surgery is the better oncological procedure, of course, because we know that 10 to 15% of very small peripheral nodules can have lymph node metastases, not only to the mediastinum, but also to the relatively inaccessible interlobar lymph nodes that even the best endobronchial merchants in the world will have difficulty biopsying pre-op. And you can see in ACOSOG, nearly 1/3 of the patients with clinical stage 1, stage 1A, had more advanced pathology at surgery. So we are not doing these patients the best possible oncological treatment. And obviously, if you don't take the lymph nodes, you're running the risk of increasing the local regional recurrence, particularly if you don't know whether these lymph nodes are involved or not. And there's evidence there that there's certainly need to improve the staging in SABR-treated patients. And the best surgery will give you better local control. Anatomical sublobar resections. The lungs are made of segments. We look at now the lung as a collection of segments rather than collection of lobes. And segmentectomy is a feasible alternative for these peripheral small tumours with favourable histopathology. There's no difference between lobectomy and anatomical segmentectomy with lymph node dissection. And so combining all those techniques, the treatment of choice for these stage 1 peripheral tumours is a VATS segmentectomy. It's a shorter length of stay than thoracotomy with fewer complications, but with experience now, there is clearly equivalent lymph node dissection. It's technically actually easier with magnification to do a proper lymph node sampling and dissection with VATS. And you can see there the minimal trauma that causes to the patient. I don't advocate wedge resection for anything other than diagnosis. It's not a good therapy. And as you can see there, the SEER registry was used to compare segmentectomy and wedge resection and showed the improved overall survival of an anatomical resection as opposed to a non-anatomical wedge resection. So is disease recurrence really similar after SABR? It looks like it. 18% distant recurrence were very similar to those reported for segmentectomy. Some have even argued that SABR may be equivalent to lobectomy because of equivalent local control. But let's look what we're actually talking about. When the surgeons define local failure, they look at recurrence within the same lobe, another lobe of the ipsilateral lung, or regional lymph node recurrence. That's what we call local failure. However, the radiotherapy definition is a slightly more lax one and defines local failure as progression at the site of the primary tumour alone or within the high-dose treatment region. Clearly, that's biasing in favour of SABR. So the assumption that the local control is the same is often wrong because the definitions are different, and local control in surgical and radiation oncology literature are not the same. We need to apply the same rigour to both. So, at best, SABR can only approximate a wedge resection. If you assume that 100% tumour destruction has occurred, then the in-lobe control away from that will always be less than 100%. It can't be a lobectomy. And therefore, surgery will give you better long-term survival. You can see there that the early results are probably comparable. But when you start to look at longer-term survival, the trends point towards surgery. It is hard to validate long-term survival if you don't have cancer to start with. Of course, that will bias some of the results. But when they updated the T-stage matched analysis from this group in St. Louis, there was an overall favour for surgery in longer-term survival, reported by other authors with lower acute toxicity from SABR, better 90-day mortality even, but inferior long-term survival. And therefore, with better early results, but poorer long-term survival, particularly from an anatomical resection, that surgery in the long term proves to be more cost-effective in reducing recurrence and the treatment required for that. And that was a series in older adults, so in the higher risk patients. But there is phase 3 data apparently to support SABR now. They've managed to pull together all the small numbers recruited into these trials. But careful analysis does throw doubt on some of the interpretations. I don't think the surgery was quite up to scratch in some of these series. Lobectomy certainly wasn't always performed. There are often wedge resections in these surgical arms of these trials, and only 1 in 5 had what we would call the gold standard, which is a VATS lobectomy. And the thoracotomy may explain, or the high rate of thoracotomy may explain the higher early mortality for surgery, as we found, particularly in the higher risk patients. There was also an unusually high survival rate in the SABR group. Well, you would expect that if some of them don't have cancer. And the histology wasn't always obtained in the SABR group. And let's not get too carried away. There was very limited power to this study, with 31 in the SABR arm and 27 in the surgical arm in this pooled data. So the question is very much open to interpretation. So, I'm afraid in conclusion, SABR, which intends to treat only the tumour with a margin of normal surrounding tissue, cannot and can never be oncologically equivalent to the removal of the tumour and the tumour-involved lobe or the segment of the lung with the associated lymph nodes. These potential off-target immune enhancement, the abscopal effects following SABR, and possibly potential scattered radiation to the microscopic disease in the lymph nodes. You can't really have it both ways. You can't give all the radiation to the tumour and then also claim to radiate the lymph nodes. But anyway, none of these abscopal effects really have ever been shown to translate into clinically meaningful benefits. They're interesting, but these aren't reasons to do non-surgical treatment in these patients. So there we have it, 7 clear reasons why we advise patients to have surgery rather than SABR. Some do still choose SABR, but majority in our practice will have surgery. God, how did he get in there? The SABR enthusiasts have a lot of financial backing. These machines cost a lot of money, and boy, do they like to make a lot of noise about it. But like Bill, as surgeons know what result will be in the end. Thank you.